Good evening, everyone. I'm Dr. Karthik, consultant radiologist at Vijaya Diagnostic Center. I welcome you all to the VDC webinar series. Today, our webinar topic is Inflammatory Bowel Disease Current Imaging Recommendations. We are pleasure to have our chief expert commentator, Dr. Sethu Babu sir. He's a senior consultant gastroenterologist at KIMS Hospital, Hyderabad. Dr. Sethu Babu sir has done his MBBS from Andhra University, MD Internal Medicine from Usmania University, DM Gastroenterology from the prestigious All India Institute of Medical Sciences. He has done his fellowship in hepatology from King's College Hospital, London, awarded FCGP by College of General Practitioners. He has done research and clinical trials, which includes 5 trials of hepatitis B vaccine, interferon in chronic hepatitis, mesalamine in ulcerative colitis. He has 13 publications in Indian and international journals. He was awarded 6 gold medals in MBBS from Andhra University and gold medal in MD Medicine from Usmania University. He is a trainer and teacher for DNB gastroenterologists at the KIMS Hospital, Hyderabad. He is a visiting faculty at various hospitals in Hyderabad. We are pleasure to have you, sir, on board. And today our subject speaker is Dr. Pritham Manohar Patil. He is a senior consultant radiologist at Vijaya Diagnostic Center. He has done his MD from Sethu Medical College, KEM Hospitals, Mumbai. I would now request Dr. Sethu Babu sir to give his opening remarks and a brief clinical perspective about the present webinar topic before we actually proceed with the seminar. Sir, Dr. Sethu Babu sir.
Yeah, I think we all know that inflammatory bowel disease is one of the most important diseases in the practice of gastroenterology. We see two important diseases. One is the ulcerative colitis, second is Crohn's disease. There is a small difference between North India and South India. It appears when I worked in North, there are lots of cases in the North, ulcerative colitis, and South India doesn't have so much as what is reported in North India. But both of them have some kind of increased maybe awareness or detection. We are able to now diagnose more number of cases. And there are three components. One is the clinical approach to the problem, number one. Number two, the confirming the diagnosis on a radiological methodology. And third is an endoscopic methodology. All three are complementary to each other. When I suspect clinically, to have a proper assessment, I do a radiological assessment and then do an endoscopic assessment, then start treating. If you ask me to put it a little straightforward, Crohn's disease has a maximum importance with radiological diagnosis compared to ulcerative colitis. I'm sure now the speaker is going to address us the important radiological approach to the inflammatory bowel disease. And now I request him to start his presentation.
Now I would request Pritham sir to proceed with the webinar.
Yeah. Can you see my screen?
Yes, sir. Now, yes, sir. Yes, sir.
Okay. Yeah. Good afternoon, everyone. I'm Dr. Pritham Patil, consultant radiologist working Vijaya Diagnostic Center. Welcome to the webinar. I'm going to talk about inflammatory bowel disease, current imaging and recommendation. I don't have any relevant disclosure, no conflict of interest. I use few copyright works for this presentation only for the educational purposes. In next 15 to 20 minutes, I'm going to talk about inflammatory bowel disease. What is inflammatory bowel disease? The role of imaging and imaging modalities, the imaging features, differential diagnosis, and conclusion. What is inflammatory bowel disease? Inflammatory bowel disease is a chronic idiopathic disease affecting the gastrointestinal tract. It has two subtypes, Crohn's disease and ulcerative colitis. Etiopathogenesis is still unknown, but it's thought to be an exaggerated, inappropriate immune response to gut luminal microbes in a genetically susceptible individuals who are exposed to environmental risk factors. It has a relapsing, remitting, lifelong illness. Peak age is around 15 to 40 years, and second peak at 50 to 80 years. Diagnosis is mainly by detailed clinical history, the physical examination, lab investigation, imaging, and the most important, endoscopy and by tissue characterization. So what is the role of imaging? Role of imaging is for the diagnosis of the inflammatory bowel disease, to differentiate Crohn's from ulcerative colitis. These two are usually achieved by endoscopy. So, main role of imaging is to know the extent of the small bowel involvement, to identify the complications such as fistula, abscesses, bowel obstruction, to assess the response to the treatment and to modify the treatment and to monitor disease activity. So, what are different imaging modalities? One is like small bowel follow through, barium enema, USG, CT and MR enteroclysis, CT and MR enterography. CT and MR enterography and enteroclysis are the imaging modality of the choice in present situations. So, briefly about what is the CT and MR enteroclysis. We need at least 6 hours of fasting. Bowel preparation is optional. It involves the insertion of nasovaginal tube under the fluoroscopic guidance, followed by infusion of a neutral oral contrast, usually water mixed with methyl cellulose. We use around 1.2 to 1.5 liter. And what is the advantage of the CT enteroclysis? It gives very better luminal distension. Uh, Only disadvantages are it is an invasive procedure, gives some discomfort to the patient while putting the NG tube, and putting the NG tube is also requires some expertise. These are the MR enteroclysis images. You can see the very well distension of the small bowel loops, and we can make out the mucosal pattern. This is CT enterography image, enteroclysis image. We can see how beautifully the bowel loops are distended. About CT and MR angiography. The procedure is nearly same, except in the angiography we give neutral oral contrast to the patient by orally. Usually we give 2% mannitol mixed with water in our institute. We give around 1200 cc in a time about 40 to 60 minutes, and 200 to 300 ml in on a CT table. What is the advantage of CT angiography? It is a very non-invasive procedure. It's very easy and it's better tolerated by the patient. Only disadvantages are we get some suboptimal distinction of the jejunum, as we can see over here in the CT angiography image. So, what is the difference between CT angiography enteroclysis and MR angiography enteroclysis? CT is very simple and fast technique. It can be performed in a single breath hold. We can take a thin sections, which gives a better spatial and temporal resolution. We can do in very less amount of the time. Only disadvantages radiation, which is approximately 8 to 10 millisievert. MR and MR angiography and glycis. No radiation. It gives a better contrast and soft tissue resolution. It's considered to be a gold standard for the evaluation of perianal fistula. Disadvantages are the time consuming. One procedure may takes around 30 to 40 minutes. It contains many sequences, more withholds, and also prone to defects, including respiratory and peristaltic. So briefly about imaging features of the Crohn's disease, is can be simply remembered by mnemonic IBD, I for inflammatory mesentery, B for bowel wall changes, and D for disease complications. So what is the features of inflammatory mesentery? We see the perienteric edema and inflammation in George Vasa recta, also known as a comb sign. Can see the small lymph nodes, fibrotic fatty proliferation of the mesentery around the bowel loop, and sometimes mesenteric vein occlusion. What are the bowel wall changes we see in the Crohn's disease? The segmental mirror wall enhancement can be asymmetric, especially around the mesenteric aspect, which is very specific of the Crohn's disease, stratified bilaminar and trilaminar pattern of enhancement, and transmural. Wall thickening can be graded as a mild if less than 5 millimeter, moderate 5 to 10, and severe more than 10 millimeter. What are the other bowel wall changes? Intramural edema, which is seen on the MR angiography, and if it is associated with the restricted diffusion, it's suggestive of a active disease. Presence of ulcerations and the bowel wall suggestive of an active disease, while sacculation, which are usually small outpouching along the anti-mesenteric aspect of the small bowel, suggestive of chronic disease. This is complication stricture. Here is the role. Here the imaging has important role, and It can use to visualize the bowel beyond the stricture. So, what is the stricture? It's defined as narrowing of a lumen of the bowel with upstream dilatation by at least 3 centimeter. When it is more than 4 centimeter, we call it a small bowel obstruction. When it is less than 3 centimeter, we usually call it like a probable stricture. What are the other complications? Penetrating Crohn's disease. CT and MR enterography, enterocolitis can be used for the better evaluation of the complication, including the sinuses, the fistula between the bowel to bowel. It is useful in the evaluation of the complex fistula between bowel to bowel, enteroenteric, between bowel to skin, enterocutaneous, with the to see the surrounding inflammation in the mesentery, as well as to see the fistula with adjoining abscess in the skin or in the surrounding mesentery. This is the one of the complication that we need to in mind while evaluating the Crohn's. This is interesting case. This is a 35-year-old male which is referred to us for the CT enterocolitis, and we can see there is an enhancing lesion within the mesentery with associated peripheral fast stranding and puckering of the bowel loop, and we can see this small enhancing nodule within the bowel. So this is the case of carcinoid, which is in a case of Crohn's disease. Few points about the ulcerative colitis. It usually involves the large bowels. Involvement of the rectum is most common. Involves most morely the left side of the bowel. Continuous involvement it shows continuous involvement. It really involves mucosa and submucosa. Strictures are rare in the ulcerative colitis, but if we see the stricture, we should do a further workup to rule out neoplasm. Pseudopolyps are known in the ulcerative colitis. This schematic diagram showing the distribution of the Crohn's disease, where the Crohn's usually show the skip areas of the involvement, while the ulcerative colitis involves the continuous pattern of involvement of the large bowel. These are the few images we're showing ulcerative colitis, showing the rectum and the sigmoid colon with stratified pattern of enhancement. This is a patient which showing the large gross dilatation of the right-sided colon with diameter more than 5 centimeter, suggesting a toxic megacolon. It's one of the complications of the Crohn's disease. This is a CT scan showing uh, diffuse thickening of the large bowels with surrounding fast stranding, ascending colon and transverse colon with perifocal fast stranding suggestive of inflammatory bowel disease. This is activity. This is the most important thing that what the physician wants to know on a radiology report. The disease active or inactive. This is important for the patient management. So, what are the features of the active disease? It's active mesentery, inflammatory mesentery, which showing the perienteric fast stranding with a comb sign, bowel wall, the mural wall enhancement, particularly stratified, presence of the submucosal edema suggestive of the active disease. This is complication including abscess, fistula, perforation, and toxic mesocolon suggestive of an active disease. While the inactive disease, the fibrofatty proliferation of the mesentery is the features of the uh, feature of chronic inactive disease, loss of normal hostile pattern, presence of the submucosal fat, mineral fibrosis, suggestive of inactive disease. Well, it is complication stricture, particularly if it's a fibrotic stricture, suggestive of inactive disease. So, what is the differential diagnosis? Tuberculosis in the developing country like India, whenever we are we are suspecting Crohn disease, always give a thought of tuberculosis. So, what are the imaging features of tuberculosis? It shows circumferential wall thickening of the terminal ileum and cecum, asymmetric thickening of the ileocecal wall. Cecum is usually contracted and pulled up due to the fibrosis. Fistula and sinuses are known to occur in the tuberculosis, but it's rare as compared to the Crohn's disease. Healing usually occurs by fibrosis, which leads to the formation of the strictures. Presence of the enlarged lymph nodes with the central necrosis is very typical of tuberculosis. This is a very interesting case. This is a young female which is referred to as, uh, and there's some problem with the media. Okay, this is a like 20-year-old female which is referred to us for the evaluation of the stricture, and she was treated for the Crohn's for the 2 years. So what we can see in this CT scan, there is a thickening of the terminal ileum over here and ascending colon, and you can see this multiple enlarged conglomerate lymph nodes and the mesentery over here with central necrosis, and some are showing the calcification. So it's very classic of tuberculosis. So, how to differentiate between tuberculosis and the Crohn's? The tuberculosis shows mural thickening without stratification. The concentric strictures are known to occur. It shows mesenteric inflammation with no enlargement of the vasa recta. Necrotic lymph nodes, very specific, very characteristic features of tuberculosis with the caseation. Ascites with peritoneal inflammation, suggestive of tuberculosis. While the Crohn's disease already we have seen in the previous slides, the mural wall thickening with stratification. Strictures are usually eccentric, mesenteric inflammation with inject vasa recta. Com sign very specific for the Crohn's disease. Lymph nodes are usually small in size. The presence of the abscess, fistula, and sinuses are suggestive of active disease, while the fibrofatty mesentery suggestive of chronic Crohn's disease, inactive Crohn's disease. So, if there is any criteria to which modality should we use for the imaging of the inflammatory bowel disease, the American College of Radiology has comes with an appropriateness criteria to which will be the modality of the choice for the imaging of the inflammatory bowel disease. So, he has given three variants, and with the variant one, and a suspected Crohn's disease with no prior Crohn's diagnosis and initial imaging. The CT abdomen and pelvis with IV contrast without oral contrast usually appropriate. CT and MR angiography are usually appropriate, while CT enteroclysis and MR enteroclysis are considered usually inappropriate. In the variant 2, in a known case of Crohn's with suspected acute exacerbation, the same CT and MR angiography and CT abdomen pelvis with IV contrast considered as usually appropriate, while CT enteroclysis and MR enteroclysis may be appropriate. The third variant, a known case of Crohn's with the disease surveillance and monitoring therapy, CT and MR angiography still scores over the CT and MR enteroclysis and considered as an appropriate. So as we see, the CT and MR angiography are the modality of the choice for the imaging of the Crohn's disease. So which should we use? So which should we be considered? So consider CT angiography patient in the case of acute emergency and in patients, ill patient. For the older patient more than 35 years, we can use a CT angiography. For the first cross-sectional imaging for the initial diagnosis, always CT angiography to rule out other small bowel disease, evaluation of the other causes of the diarrhea, and if there is any contraindication for the MRI. Consider MR angiography if there is a prior history of CT angiography for the outpatients. For the young patients, always MR angiography. For the follow-up imaging and to see the response to the treatment, MR angiography is the modality of choice. For the perianal fistula and the disease, it's the gold standard. We can use MR angiography in the in the pregnant patient, but without any IV contrast. If there's any allergy to iodinic contrast, consider MR angiography. And finally, it all depends on the local imaging access and expertise, and what the referring physician wants. So finally, what the referring physician wants from the radiologist and the reporting. He wants to know is it the IBD or not, or can we differentiate between these two? Usually, this can be achieved by endoscopy. The important thing is want to know the number of the bowel segment involves, the location from the ileocecal wall, the ligament, and from the location from the ligament of the threads, a number and location and the length of the stricture and degree of the upstream dilatation, presence of an active inflammation within the stricture. This is very important because presence of active inflammation with the strictures goes for the medical management, where the fabric stricture with the obstruction goes for surgical management. Presence of impenetrating disease, actimural inflammation, any comment on the perianal disease, and finally any signs of neoplasm, which suggestive of like such as symmetric thickening, nodularity, and soft tissue thickening in the adjoining mesentery. Finally, in the conclusion, cross-sectional imaging play a vital role in the diagnosing and distribution of the disease and to assess the response to the treatment and the disease progression. It helps to differentiate between active and inactive disease, diagnosis complications, extraintestinal manifestation, including neoplasm, Standardized terminology in the reporting would help in the medical and surgical management of the patients. Thank you.
Thank you, sir, for a wonderful and elaborate presentation. Dr. Sethu Babu, sir, we are not able to see you, sir. Can you turn on your video, sir?
Uh, are you able to see me? No.
No, sir. Yes,
Okay,
sir.
but you're
Yes.
yeah, okay. I'm actually reaching home. Anyway, there is only one very important troubling issue in most of our patients is you put in duodenal tube that makes them little uncomfortable.
Right.
So could you find a better solution that you don't put the tube, maybe give some buscopan or something like that?
For doing the imaging, you're saying, sir?
Yeah, imaging.
Yeah. So we for doing MR graphy and enteroclysis, we generally give busbocan to the patient just to decrease the
Relax the
peristaltic, yeah, to see to decrease the peristaltic activity. But I think enterography is like a more preferred modality over the glycis for the evaluation of now small bowel Crohn's. Only disadvantage is the suboptimal opacification of the jejunum, because when we take the patient on the table for the imaging, usually there'll be some time gap of 1 to 1.5 hour, and usually during that time the contrast from the jejunum will come to the ileum. So we can put the patient on the table in the right decubitus position for 5 to 10 minutes, and which will opacify the proximal portion of the jejunum. That can be helpful.
Yeah, if you can do it tubeless. In fact, when I write a requisition, I write, please
Right,
don't put the tube, somehow manage the study.
right,
That was a request.
right.
Then, you tell me honestly, would you suggest an MR enterography or CT enterography, which you are comfortable in reporting?
On the first time scan, I'm definitely comfortable with the CT angiography, because I want to see the distribution of the disease, where it is actually. And in the follow-up imaging, if I know where was the disease, so I can just concentrate my MR angiography in that particular area, and also to look for any other strictures. So the first time, always CT angiography and more comfortable, but for the follow-up MR angiography, we can evaluate the, we can avoid the radiation, and we can do a good job for the patient.
My last comment is you are aware of this capsule endoscopy?
Yeah, I read
Yeah.
about it.
So no. This capsule endos, I'll tell you where the important role comes is
So,
we do CT or MR study of the small bowel, and if you find an absolute stricture, we may not advise them either enteroscopy or capsule endoscopy because the stricture is unnegotiable.
right,
There is now a motorized capsule endoscopy, which is the novel, instrument where you can actually drive your capsule using an external robo machine. Actually, so I think the advances have been so great that. But one thing that one should remember is each one is complementary to it. Nothing
right,
is the final. So if I find a stricture, I would there stop and treat the patient in a different way, maybe surgery.
right.
It's a good presentation. I appreciate the content of it.
Thanks.
Sir, do you have
Any
any more
question?
remarks to make, sir?
No. It's a good presentation. Actually, it's the standard presentation. With the advent of enteroscopy and colonoscopy, we do not actually do too many of these studies, except there are a couple of areas like when you are suspecting a long segment Crohn's, you might or you want to do the resectability of a lesion, then we our enteroscope stopped somewhere in the proximal jejunum. We might resort to this particular study, but in my own practice, I always do this as a baseline investigation.
So, Pritham, sir, would you like to add any more points?
Uh, Yeah, it's only when I read, there's two nice article and two journals in radiology and radiography, and uh, when I read those article, I think uh, it's a very nice article. Everyone should read it, and for the patient points of view. I've always prefer the enterography or the enteroclysis, because the putting of the tube it's very discomfort to the patient. So I feel we should use CT angiography as a standard imaging modality for the imaging of any small bowel Crohn's or any other abdominal pathology.
Do you use Riles tube or Freca tube?
Uh, uh, we
I'll tell
use
you the
a
difference. I'll
stuff.
I'll tell you the difference. The difference is Freca tube is very friendly and it has a guide wire, whereas Riles tube is very crude. And so whenever we do in clinical practice, I'm one who hate Riles tube and I put only Freca tube, very smooth. And then it is easy negotiable. It has a guide wire inside.
Yeah, I think we use the second one, sir. I
Yeah,
don't, we don't know the name, but it has a guide wire
yeah,
when
it should be the one. Yeah,
yeah,
that's what I'm.
yes,
I'm just
yeah,
trying to draw the attention.
yeah,
That's quite. It's good. It's a very good presentation.
yeah. Thanks, sir.
Thank
I
you.
think,
Then, yeah,
I
is it
think,
okay?
yes, sir. We don't have any comments from the audience as well. I think it
No.
was a wonderful session, sir.
Yeah.
And thank you, Sethu Babu, sir, for joining us and giving your valuable opinions and enlightening us about this the inflammatory bowel disease, including capsule endoscopy and all that advances. We heartfully thank you for this for
No, I
joining us.
must thank you. I must thank you because allowing me to participate and make comment. Thank you very much.
Thanks, sir. Thank you,
Thank
Vijaya
sir.
you very much,
Diagnostic
Patil,
is
sir. It
real
was an
good.
excellent presentation, sir.
Thank you, Karthik. Thank you, Sethu, sir.